It's interesting that today we've reached a stage that we're discussing osteoporosis where nothing much is known. We still believe it's an incomplete science. It will be an infinite game where there's something called expertise, which is going to be a balance between experience and evidence. And here I am to tell with you when to operate, when to optimize, and when to omit surgical procedures, especially in the bone. Well, is it an aging process or is it a pathology? This is a slide borrowed from Abhay and modified. Well, we do fusions depending on why we do it. We do it to stabilize painful joints, correct deformities, or get an indirect decompression. We have various procedures from PLF to P-lift, T-lift, O-lift. The basic idea is to do a decompression, and decompression can be done and should be safely done, even in the osteoporotic spine. The problem doesn't happen there. The problem is then how to protect it, or whether you need fusion. Will you use a complete solid fusion? Will you use a hybrid or a mobile fusion? Will you use non-fusion options? Or would you look at interspinous or arthroplasty? Well, we've used mixed matched over the years, and we've at times gotten away. But this happens in the younger. As we grow older, do we have a cost-saving, lasting effect? Well, I don't know. This is something I did years back when I used to use mesh cages. At that time, we hardly did DEXAs. And we found that this cage was posterior, that is what we thought, but over a period of time, there was subsidence. We also had patients where even the X-ray and MRI both now retrospectively look like osteoporotic, and we put in these spacers, mesh cages, which sunk all the way in. Smokers, and we blamed it to them, everything happened. A combination of sinkage as well as the backing out of the implant. Over a period of time, combination and late sequelae of the same. I then decided that I would combine and get an expertise statement for myself. One, if you have a T-score on a recent DEXA, what I call less than 2 years, which is less than or equal to minus 2.5, anywhere in the skeleton. I'm not saying only specific spine is worst. Diabetic or smoker with a T-score less than or equal to minus 2. Steroid, patient we believe has glucocorticoid-induced osteoporosis, thyroid medication, seizure medication, Parkinsonism, or a defaulter with anti-osteoporotic medication. In all of these, we have to either omit or optimize the surgery. Only place where you will operate is if there is a red sign of cauda equina syndrome or a recent clinical worsening under treatment. So what do we do? How do we optimize them? We reassure them, we brace them, we give them critical observation, follow-up, maybe video consults, aggressive anti-osteoporotic therapy. I use teriparatide, I use denosumab, I use combination therapies in treatment naive, I give them calcium, vitamin D, fall prevention at home, and review them at 3 to 6 months for surgery with this high-dose combo. Then I could do PLF, I could do PLF the way I want, I could then do PLIF, I could do anything that you want, a TLIF, you could then do an OLIF, any or all of these. I have nothing against the procedures. However, when we are in a situation where we need bailout, what do? Can we do uninstrumented fusions with autograft, with BMP, bone morphogenic protein, plus customized bracing post-op? Maybe yes, maybe no, but there you have to limit your decompression to keep stability. Maybe keep the midline intact, don't go too lateral. Can you use cement augmented screws, fenestrated screws, or HA coated screws? Yes, you may. Multi-segmental fixations, dual modality screws plus sublaminar wires, bands, and of course, the complete workhorse that you go back to, which is hard shield with sublaminar. Stainless steel rods, stainless steel wires. What are the lessons that I've heard? Whenever we are doing fusion in the elderly, and we have to do it in many situations, remember that's only when the symptoms are more than the signs. That means you don't find anything, but the patient is really moribund because of symptoms, let them buy the operation. Only when signs are more than symptoms that you counsel them for surgery. Elderly osteoporotics, aggressive medical therapy. That means operate them, but after you've optimized them. Complex LCS, which includes degen scoles, redos, less is more. Don't do those massive constructs. Instrumentation, where necessary, use BMP, where necessary, use cement either to augment the screws or as a spacer intracorporal, use screws and wires and maximum combinations. Whatever you have with you, you may be sitting in Pune and have an option, well, use it, technology and technique. Tertiary care, comorbidities, always have an ICU backup, and do not do these in centers where you don't have a proper post-op care. Future, will it be fusion, maybe non-fusion? Will it be minimally invasive or open, instrumented, non-instrumented, gene therapy, biologics, metal? We don't know. Please remember that today we are going through spinal surgery where things what we talk today may be obsolete tomorrow and history the day after. Do what works best in your hands, in your setup today. I'm saying something not just for you to hear, but to listen and think about. Always remember, we have to start with why we are doing the surgery. Just putting in those screws the way they were put, in a few days, that's what happens at the bottom. Do it and do it precisely. A very important thing to remember, behind every successful person, there are a lot of unsuccessful years. Good results come from experience, but experience comes only from bad results. The Dunning-Kruger effect is important. The more you know, the less confident you're likely to be, because experts know just how much they don't know. They tend to underestimate their ability, but it's an easy to be overconfident when you have only a simple idea of how things are. Try not to mistake the cautiousness of experts as a lack of understanding, not to give much credence to lay people who appear confident but have only superficial knowledge. Very important, the whole problem with the world is that fools and fanatics are so certain of themselves, yet wiser are so full of doubts. Thank you very much for a patient hearing.